applicants today. We're just trying to find out if you're a little crazy and whether you can fit in or not. It pays to be a little bit off. This morning we're going to have Dr. Mark Muir, one of our chief residents, presenting grand rounds talking about early breast cancer. Dr. Muir grew up in Dallas, went to undergraduate at UT Austin, and then emigrated back to Dallas, where he went to UT Southwestern for medical school. He graduated AOA and then came down here for his residency. He spent 2 years in the lab, and after his residency here, he is joining the Trauma Emergency Service as a critical care and trauma fellow July 1st. Mark?
All right, thank you. This morning I'm going to be talking about early stage breast cancer. Obviously that's even limiting it to early stage is a fairly broad topic, so several parts of this talk will be sort of broad overviews, but there are areas where I'll go into considerably more detail. As far as the epidemiology of breast cancer, obviously I don't need to tell anybody in this room what a public health burden it is. It's the most common cancer among women, at least in the United States. 1 in 8 women will develop breast cancer at some time during their life. As far as cancer mortality from breast cancer, it's second only to lung cancer in the United States. So despite the fact that treatments have improved and mortality is declining, it's still 40,000 deaths a year roughly from breast cancer in the United States. And over the last several decades, while the mortality has been going down, the incidence has been creeping up, presumably due to increased quality of screening and detecting new cases. There's several parts of breast cancer that I'm going to sort of skip over just in the interest of time and focusing on purely invasive breast cancer. I won't really discuss pre-invasive diseases and situ disease. I'm not really going to go too much into screening for breast cancer either. This is the preoperative evaluation of a patient who's now been diagnosed with breast cancer and who's being considered for treatment. Most of the parts of the routine evaluation are pretty much common sense, history and physical, laboratory work to include at least CBC, LFTs, alkaline phosphatase, a bilateral mammogram if the patient hasn't already had one. Review of outside pathology at your own institution is important to confirm the pathologic results. Determination of estrogen and progesterone receptor status, determination of HER2 status, genetic counseling in certain high-risk individuals, patients with a known family history of breast cancer or at high risk for hereditary breast cancer. And in certain circumstances, breast MRI may be useful. I'll discuss that a little bit more on the next slide. That's really all the routine workup that's necessary in most patients, at least with early stage breast cancer. Any other workup or imaging should be dictated solely by exam findings or specific lab abnormalities. Bone scan may be considered if patients are having localized bone pain or an elevated alkaline phosphatase level. CT abdomen, pelvis, or CT chest, really only if they're having either abdominal complaints or pulmonary complaints that would suggest a problem. Indications for diagnostic breast MRI are somewhat controversial, and I'm not even going to get into screening breast MRI at this point. Compared to mammogram, MRI can detect up to additional disease up to 20% of the time in the ipsilateral breast. So if you have a known breast malignancy diagnosed on mammogram, either multicentric disease or more extensive disease of the primary may be detected up to 20% of the time using MRI. However, the limitation of MRI is the high false positive rate. The positive predictive value, even in the breast known to contain malignancy, is only 67%, and only 37% in the contralateral breast, so a significant number of false positives. Plana et al. In 2012 did a meta-analysis of previous studies looking at diagnostic breast MRI, and specifically they were looking at the utility of breast MRI for determining surgical therapy, whether or not a patient was a candidate for a partial mastectomy or whether or not they would need a total mastectomy. What they found is that approximately 19% of patients using MRI had a upstaging, essentially an increase in surgery from a partial mastectomy to a total mastectomy. But when they went back and reviewed the final pathology, they found that 13% of those, that was the appropriate treatment, that they did have more extensive disease that would have been missed on mammogram that led to total mastectomy. However, there was approximately 6% of women that ended up with a total mastectomy that may have been unnecessarily, that they may have been able to have just a lumpectomy, and that the breast MRI led to some false positive Some specific situations in which breast MRI can clearly be useful include diseases where you have an unknown breast primary. Two that I'll talk about towards the end of my talk: axillary breast cancer with no definitive breast cancer, as well as Paget's disease. Breast MRI can have some utility in those situations as well. I'm going to sort of go quickly through the workup and staging of breast cancer. Breast cancer follows the TNM staging system. This is mostly review for the students in the audience. Carcinoma in situ includes DCIS, LCIS, and Paget's disease. I'll talk about Paget's. Dr. Jatoy gave a grand rounds recently on DCIS. And then after that, the T stage is based primarily on tumor size, less than 2 centimeters, 2 to 5 centimeters, or greater than 5 centimeters. T4 is a disease with direct extension involving the skin or the chest wall. Lymph node status can be based both on clinical stage, which is based on the preoperative assessment, as well as pathologic stage based on the final pathologic specimen. For purposes of this talk, I'm going to primarily be focusing on N1 disease, as N2 and N3 disease are more advanced stage breast cancer. N1 clinically is mobile ipsilateral level 1 and 2 axillary nodes. If the nodes become fixed or matted, if you develop have internal mammary nodes or supraclavicular nodes, it becomes either N2 or N3 disease. Pathologic stage is similar to clinical stage, with the primary difference being that now the stage is based on the number of axillary lymph nodes positive rather than whether or not they're fixed or mobile. 1 to 3 positive nodes are considered N1, 4 to 9 would make it N2, and greater than 9 would make it N3 disease, with the rest of the criteria being essentially the same. And this is the table summarizing the overall stage based on the T, N, and M classification. The area highlighted there in yellow is primarily what the focus of my talk will be on, the more early stages. So primarily T1 and T2 tumors, N0 and N1 disease. Although T3 tumors greater than 5 centimeters are stage 2 if they have no nodal involvement. So now I'm going to talk about the therapy of breast cancer for a while. The therapy of breast cancer is broken down into several components, including surgical therapy, radiation therapy, adjuvant chemotherapy, and endocrine therapy, each of which I'll address individually. The surgical therapy options for early stage breast cancer include the following: partial mastectomy or lumpectomy, either with sentinel lymph node biopsy or with axillary lymph node dissection if the nodes are clinically positive or if they have a positive sentinel lymph node. The other option is either a total mastectomy with sentinel lymph node biopsy or a modified radical mastectomy. As far as the data concerning mastectomy versus breast conservation therapy, there's been a number of large randomized controlled trials. To date, 6 randomized controlled trials have compared mastectomy specifically with partial mastectomy. And what the data shows is that when you compare mastectomy to lumpectomy followed by whole breast radiation, that the local recurrence rate is somewhat higher in the group that has lumpectomy followed by radiation, something on the order of 8 to 14% compared to 1 to 2% with mastectomy. A couple of things I point out is that, one, it's important to note that even with mastectomy, the recurrence rate is not 0, that there is still a small rate of local recurrence. But the other thing that these trials are fairly consistently show is that there is no difference in overall or disease-free survival regardless of which therapy is used, which suggests that while there may be some local recurrences in the lumpectomy group, that those are, can usually be effectively treated with re-excision and additional therapy. On the next few slides, I'll talk some about radiation following breast conservation therapy. I'm just going to mention briefly, there are a few indications for radiation even in patients that have a mastectomy. Again, this tends to be more advanced disease and will be discussed in a subsequent grand rounds, but briefly, tumors over 5 centimeters, T3 tumors, or tumors that have a positive margin after mastectomy will generally benefit from radiation. Additionally, patients with more than 3 positive axillary nodes, so essentially N2 disease, benefit from radiation post-operatively. 1 to 3 positive nodes is somewhat controversial. The data is somewhat mixed. And there's not really a clear consensus on radiation therapy in less than 4 positive axillary lymph nodes. So as far as the size of margins following partial mastectomy, traditionally the teaching and the thought among textbooks and surgeons has been that margins should be somewhere 0.5 centimeters to over 1 centimeter are considered adequate. And in patients that had lesser margins than this would even be considered for re-excision to obtain wider margins. Husami and Associates in 2010 did a meta-analysis of the previous studies looking at this, and what they found was that, not surprisingly, in patients with positive margins, the odds ratio of local recurrence was 2.4. Again, not surprising that patients with positive margins would have a higher rate of local recurrence following mastectomy. But what they also found was that in the patients with negative margins, when they stratified it by margin size, there really was no difference in local recurrence rates. It didn't matter if the margin was 1 millimeter, 2 millimeters, or 5 millimeters. There was no significant difference in the local recurrence rates. Morrow and Associates wrote a subsequent review in New England Journal of Medicine last summer and came to essentially the same conclusions, that basically at this time there's no evidence to suggest that wider margins are better for local control, that if there's even a single cell layer between the tumor cells and the inked margin of the specimen, that should be an adequate resection margin, and that any residual tumor burden should be adequately controlled with the subsequent radiation therapy that patients will get. Why do patients undergoing partial mastectomy need radiation therapy afterwards? This is a summary of the data, again, another meta-analysis from 2011, in which they looked at two endpoints. They looked at 10-year local recurrence and they looked at 15-year mortality rates. And what they found is that for both outcomes and for all groups, the outcomes were better in those patients who had postoperative radiation therapy to the whole breast following lumpectomy. There was a reduction in the 10-year recurrence rate of 35% to 19% in those patients who got radiation. This benefit held for both node-negative and node-positive patients. And again, not surprisingly, the benefit was even larger among node-positive patients because these patients are at a significantly higher risk of local regional recurrence in the axilla. Likewise, the mortality, 21% mortality versus 25% for those without radiation. And again, for both node-negative and node-positive patients, there was a benefit when lumpectomy was followed by radiation therapy. So a clear survival and recurrence benefits to lumpectomy followed by radiation. So essentially all patients who are undergoing a partial mastectomy breast conservation therapy should be counseled to receive radiation post-op, and patients that aren't candidates for radiation really are generally not candidates for partial mastectomy, with one exception. There's a couple of studies that have shown that in patients with a particularly favorable tumor profile and whose risk of dying from all causes is higher than their risk of dying from tumor recurrence, the radiation can probably be omitted. What they've concluded is that patients that meet all 5 of these criteria, so women whose age is over 70 years, women who have node-negative disease, women who have a T1 tumor, so a tumor smaller than 2 centimeters, whose tumor is estrogen receptor positive, and who are going to receive adjuvant endocrine chemotherapy, so in other words, women who are a candidate for post-treatment aromatase inhibitors. If patients meet all 5 of those criteria, that they can omit radiation therapy following lumpectomy. They did show that the local recurrence rates, again, are somewhat higher without radiation, something in the order of 4 to 8% versus approximately 1% with radiation. But again, given the favorable tumor prognosis and the increased risk of dying from all causes, that there's really no difference in total or disease-free survival. And then there are, again, women in whom there are contraindications to breast-conserving therapy. These women should generally undergo a mastectomy. Not all of these are absolute contraindications, and most of these are based on the fact that these women are not candidates for radiation and therefore not candidates for lumpectomy. So women who have had prior breast or chest wall radiation, who may have already received the total acceptable dose of radiation to that region of the body and therefore can't get any more radiation. Pregnant patients, pregnancy obviously is a contraindication to radiation because of its effects on the fetus. Again, there are some exceptions, and I'll talk about pregnancy and breast cancer in a little bit later section of the talk. Patients who on imaging have either multicentric suspicious or malignant appearing calcifications, these patients, it wouldn't be possible to excise all of the suspicious areas in one lumpectomy specimen, so they should generally undergo mastectomy. Women in whom have just a unicentric tumor, but in whom they might have an unacceptable cosmetic result due to the fact that the primary tumor relative to the woman's breast size is too large to excise with a good cosmetic result. Now again, this is sort of a relative contraindication. Many of these women may qualify for neoadjuvant chemotherapy to shrink the size of the tumor, and following therapy may be able to excise the tumor with a partial mastectomy. Women with active connective tissue diseases, primarily scleroderma and lupus because of the risk of vasculitis and local wound complications following radiation. And then finally with known genetic predispositions, predominantly BRCA1 and 2 known carriers whose risk is high enough that they should be considered for prophylactic bilateral mastectomy. Now I'm going to transition from discussion of treatment of the primary tumor to treatment of the axilla. I thought it would be appropriate to introduce this section with some covers of Axilla magazine, which is indeed a real magazine. Armpits galore in our pilot issue. And for anyone interested, it apparently is a free magazine. The borders of the axilla, this is just sort of a review of the anatomy and the borders of the axilla. The landmarks used when you're performing an axillary dissection, axillary clearance, the latissimus dorsi forms the posterior and lateral border of the axilla. The pectoralis major here reflected forms the anterior border of the axilla. The pectoralis minor, the nodes posterior to that are going to be the medial border. The long thoracic nerve running along the serratus here is the posterior border of your dissection. And then the axillary vein, shown here is the subclavian vein. Once it crosses under the clavicle, the axillary vein forms the superior border of the axillary dissection. Essentially, all of the lymphatic and fatty tissue and that within those margins should be removed during an axillary lymph node dissection. I was also just going to point out the intercostal brachial nerve here. This is a cutaneous extension of the T2 intercostal nerve. It's a cutaneous nerve, a sensory nerve to the inner upper aspect of the arm. As far as the levels of axillary lymph node dissection, I previously mentioned level 1 and 2 axillary nodes. Level 1 nodes are those that are, let's see where the pointer is. Level 1 nodes are those that are lateral to the pectoralis minor. Level 2 nodes are deep to the pectoralis minor, and level 3 nodes are those that are medial to the pectoralis minor. Generally, during axillary surgery for breast cancer, we only perform a level 1 and 2 clearance unless they have preoperative evidence of level 3 nodes or grossly positive level 2 nodes during the dissection. This is sort of an important distinction to make when performing an axillary dissection for other malignancies, particularly for melanoma. You generally perform a complete level 1, 2, and 3 axillary dissection. But in breast cancer, without evidence of positive nodes, level 1 and 2 clearance is all that's required. And again, that also forms the distinction between N1 disease, which is confined to level 1 and 2 nodes, versus more extensive disease of the axilla. As far as the utility and outcomes following sentinel lymph node biopsy, there's been a number of studies. These are two of the larger ones comparing routine axillary lymph node dissection with sentinel lymph node biopsy followed by selective axillary dissection only in patients who have a positive sentinel lymph node. Sensitivity, specificity, and accuracy of sentinel lymph node biopsy all listed there and all quite high. They also showed that there was no difference in local recurrence, overall survival, or disease-free survival between patients undergoing routine axillary clearance versus patients with sentinel lymph node biopsy. So clearly shows that sentinel lymph node biopsy is safe. Outcomes are no worse. So what are the benefits of sentinel lymph node biopsy over routine axillary dissection? Primarily, there's some small reductions in morbidity following the surgery. Patients have shorter hospital stay and shorter return to normal activities due to decreased pain and decreased limitations of range of motion of the affected arm. Also, more long-term results at 12 months, patients have lower rates of lymphedema and lower rates of sensory loss in the affected extremity compared to complete axillary lymph node dissection. A couple special situations for lymph node biopsy that I was going to address. One is the timing and performance of sentinel node biopsy in patients who might be undergoing neoadjuvant chemotherapy. There are some studies that have been done. Sentinel lymph node biopsy following neoadjuvant chemotherapy is feasible and safe, while the percentage of patients in whom sentinel lymph nodes were able to be identified was slightly smaller. It is a significant difference, but clinically it's a fairly small difference. Still, the overwhelming majority of patients are able to identify a sentinel lymph node even following neoadjuvant chemotherapy. The false negative rates are similar. The NCCN guidelines recommend performing a sentinel lymph node biopsy prior to neoadjuvant chemotherapy. The rationale is that there's a possible risk that patients could have a complete response and that therefore performing the sentinel node biopsy after neoadjuvant therapy might result in understaging. Essentially what that means is in a patient who for example, had microscopic metastases to the axillary lymph nodes, they undergo neoadjuvant chemotherapy, and now on post-chemotherapy sentinel lymph node biopsy, those nodes are negative, would effectively be understaged, since staging is generally based on their stage at time of presentation, not following chemotherapy. The downside, of course, is that requires 2 surgeries. The patient undergoes a sentinel lymph node biopsy followed by neoadjuvant chemotherapy, followed by a second operation for definitive removal of the tumor, as well as any additional axillary dissection. So if a patient has a positive sentinel node prior to neoadjuvant chemotherapy, they would still undergo their chemotherapy and then have definitive axillary clearance at the time of their breast surgery. And finally, more recently, there's been a couple of studies looking at is it even necessary to perform a complete axillary lymph node dissection in the setting of a positive sentinel lymph node. This is a study and an update of that study. These patients looked at favorable tumors. They looked at patients with only T1 or T2 tumors, so primary tumors less than 5 centimeters. They focused on patients who had only 1 or 2 positive sentinel lymph nodes, in patients that were undergoing breast conservation therapy and who were going to undergo subsequent radiation therapy to the breast, and in patients who had not had any neoadjuvant chemotherapy. What they found is that in patients that met all of those criteria, at least at the follow-up, which at this point was at 6.3 years, there was no difference in local recurrence rates, disease-free survival rates, or overall survival rates. So this suggests that in patients who meet all of those criteria, who have only 1 or 2 positive sentinel lymph nodes, you can actually skip the axillary lymph node dissection and save the patients the associated morbidity. There are some concerns with that. Of course, one is that the length of follow-up, maybe with longer follow-up, there would be more recurrences or mortality. The other concern is the possibility that while there may not be any improvements in outcome, there's, of course, a possibility of, again, understaging, that there may be additional nodes detected if you perform a full axillary clearance. And those additional nodes, if they upstage the patient from N1 to N2 disease, could lead to a different regimen. So in these patients, you can consider avoiding axillary lymph node dissection, but certainly the consensus is not uniform on that at this point. Now I'm going to switch, and I've sort of discussed the surgical therapy for both the primary tumor as well as the axilla. Now I'm going to transition and talk a little bit about adjuvant therapy for early stage breast cancer. So this is therapy once the patient has had their tumor removed and any necessary axillary surgery, additional therapy to reduce recurrence and to improve survival. Specifically, I'm going to talk about chemotherapy, endocrine therapy, as well as Herceptin trastuzumab, which is a monoclonal antibody against the HER2 receptor. Indications for adjuvant chemotherapy. Only a small select subset of patients generally will not receive some sort of chemotherapy. So patients with a primary tumor less than 0.5 centimeters and negative nodes, in these patients, their outcome is so favorable and chance of recurrence or dying from their disease is so low that it would be difficult to show any benefit to chemotherapy. Patients whose tumors are between 0.5 centimeters and 1 centimeter and have negative nodes fall into a little bit of an uncertain gray zone. Certainly patients with unfavorable characteristics, so patients with lymphovascular invasion, patients with high nuclear grade, patients with high histologic grade, HER2 positive patients, or ER/PR negative patients generally should be considered for systemic chemotherapy. And then finally, in patients with a tumor greater than 1 centimeter, or in any patient with positive lymph nodes, should undergo systemic adjuvant chemotherapy if they're a candidate for it. There are some additional methods for risk stratifying these patients, including oncotype, basically gene arrays that look at a panel of the patient's genes and essentially provide based on the expression of those genes, provide a score that estimates the risk of recurrence in those patients, and that can be one of the sort of newer modalities for trying to determine whether or not the risk of chemotherapy is outweighed by the benefits in some of these patients in this kind of gray zone in the middle. Adjuvant endocrine therapy, this applies to patients who are ER or PR positive who have estrogen receptor or progesterone receptor expressed by their tumor. Generally, all patients that are ER/PR positive should receive some form of adjuvant endocrine therapy. Again, for patients who have very favorable tumors, very small tumors, or even sort of 0.5 to 1 centimeter tumors with, again, favorable factors, as I discussed on the previous slide, because their outcome is so good to begin with, the rates of local recurrence and rates of dying from disease are so low, difficult to show any benefit from endocrine therapy, but because again, the side effect profile is somewhat less than for systemic chemotherapy, generally these patients will be treated regardless. The treatment regimens for premenopausal women generally consist of tamoxifen given for 5 years. For postmenopausal women, the standard treatment is an aromatase inhibitor, or Arimidex, for 5 years. And the data suggests that aromatase inhibitors actually lead to a greater decrease in tumor recurrence than tamoxifen, about 44% versus 32% for tamoxifen. The way aromatase inhibitors work is they block peripheral conversion of estradiol to estrone. In premenopausal women, this isn't particularly effective because they still have ovarian production of estrogen. Postmenopausal women, if they're not a candidate for aromatase inhibitors, either they can't tolerate them because of the side effect profile, or the primary reason being osteoporosis, which is exacerbated by the aromatase inhibitors. Postmenopausal women can take tamoxifen as well, or a combination of tamoxifen and aromatase inhibitors for 5 years. Herceptin. Herceptin is a monoclonal antibody, like I mentioned. In patients whose tumors overexpress HER2/neu, human epidermal growth factor receptor 2, these patients benefit from postoperative from adjuvant Herceptin. Typically, Herceptin is administered over 52 weeks, so it's given over the course of a year, and it's always given in combination with chemotherapy, usually with a regimen containing either paclitaxel or docetaxel. The largest studies, the randomized controlled trials that have shown a benefit with Herceptin, all included in one of those chemotherapy regimens, so it's standard to give Herceptin as part of one of those regimens. Herceptin in patients that are HER2 positive actually leads to an even greater decrease in recurrence than either systemic chemotherapy or endocrine therapy. Patients have a decreased recurrence of anywhere from 46 to 55%, as well as an improved disease-free survival. As far as the sequence of all of these adjuvant therapies, once the patient has had surgery, what order should they receive chemotherapy, endocrine therapy, radiation therapy? There's been a couple of studies shown there that looked at administering radiation therapy both prior to chemotherapy as well as following chemotherapy. There were really no differences shown in local recurrence or survival, but there was a decrease in distant metastases at 10 years with patients that got chemotherapy first. Presumably this is due to the fact that chemotherapy essentially is used to treat the systemic disease, the circulating cells, whereas radiation therapy is for local regional control. And that patients who've had their primary tumor resected, the priority is treatment of any systemic disease prior to treating any residual tumor burden. So the typical sequence of therapy following surgery usually consists of chemotherapy with or without Herceptin. Obviously in HER2 positive patients that would be combined with Herceptin, followed by radiation therapy as well as endocrine therapy if they're ER or PR positive. Now I'm going to talk about some sort of select circumstances, some special circumstances with regards to early stage breast cancer that fall outside of some of the previous guidelines. As far as breast cancer and pregnancy, approximately 1 out of 10,000 live births are complicated by a new diagnosis of breast cancer. It tends to be more advanced. Over 90% of these patients present with either stage 2 or higher disease. Presumably this is due to the fact that patients seek attention later and the threshold of suspicion is lower in these patients because they generally tend to be young women. They're more often ER, PR negative as compared to non-pregnant women. Mammogram is still highly sensitive for detecting the primary lesion with shielding of the fetus, positive in up to 90% of patients. Ultrasound is positive in over 90% of patients for detecting a primary lesion. As far as the treatment of malignancy during breast malignancy during pregnancy, the traditional thought has been that a modified radical mastectomy is the best option in a woman that wishes to continue the pregnancy for a couple reasons. One, mastectomy obviates the need for any postoperative radiation therapy to the breast, which is obviously contraindicated because of the risks to the fetus. Additionally, by performing routine axillary clearance in these women, there's no need for sentinel lymph node biopsy. And again, the small but possible risk of radiation injury to the fetus. However, there are a number of small studies listed there at the bottom. These mostly have something on the order of 15 to 20 patients, but they do show no difference as far as recurrence or long-term outcomes when comparing breast conservation therapy, either with immediate radiation and shielding of the fetus or delayed radiation until the postpartum period. Additionally, patients who are pregnant and have breast cancer can undergo systemic cytotoxic chemotherapy. The recommendations are that you wait until after the first trimester until the greatest risk of teratogenic effects to the fetus have passed. And chemotherapy should either be completed or at least be discontinued before the 35th week or more than 3 weeks before the planned delivery. That's primarily to avoid any hematologic complications at the time of delivery due to residual chemotherapy effects. Endocrine therapy, like radiation therapy, is contraindicated due to concerns about effects on the developing fetus. Sentinel lymph node biopsy in pregnancy. I'd mentioned that traditionally routine axillary lymph node dissection is the standard of care. However, there are some studies, again fairly small studies, but they do show that sentinel lymph node biopsy is feasible and safe in pregnant women. These studies looked at patients in the third trimester. They found that they were able to identify the sentinel lymph node in over 90% of patients, and they had no reported fetal abnormalities in their series. There's an additional study in which the authors attempted to estimate what the actual fetal radiation exposure would be from performing a sentinel lymph node biopsy using radio-labeled sulfur colloid. Their estimates were that it would be around the range of 0.014, which is significantly less than the upper limits recommended by the CDC for pregnant women. So again, they conclude that sentinel lymph node biopsy is most likely safe in pregnant patients, particularly past the first trimester. If a sentinel lymph node biopsy is to be performed in a pregnant patient, it should be done with radioisotope, as any of the blue dyes, lymphoserum blue, methylene blue, isosulfan blue, are all class C and are generally considered contraindicated in pregnancy. So the algorithm for treatment of breast cancer during pregnancy varies by trimester. During the first trimester, if the one option is a termination of the pregnancy and then proceed with treatment just as any other circumstances. But if the woman wishes to continue the pregnancy, options include mastectomy with some form of axillary staging, whether or not this be sentinel lymph node biopsy or axillary dissection. Chemotherapy is delayed until the second trimester, as I mentioned previously, and then any additional radiation therapy or endocrine therapy is delayed until the postpartum period. For patients already in the second trimester or the early third trimester, again, surgical treatment options are similar: mastectomy, or in this case, lumpectomy, followed by axillary staging, sentinel lymph node biopsy, or axillary dissection. Chemotherapy can be initiated as soon as a patient has recovered from surgery, as they're far enough along in the pregnancy. And then again, any radiation or endocrine therapy would be delayed until the postpartum period. And finally, patients presenting in the late third trimester towards the end of the pregnancy is actually fairly straightforward. Generally, those women will undergo surgical treatment of their breast cancer at the time of diagnosis, again, either mastectomy or lumpectomy, followed by axillary staging. And then any additional radiation therapy, chemotherapy, or endocrine therapy can be safely delayed until the postpartum period, given that their date of delivery is close. Another situation I'll discuss briefly is breast cancer in men. Fairly rare occurrence, approximately 1% of all breast cancers. The highest risk factors for breast cancer in men are BRCA2 gene as well as Klinefelter syndrome. Men tend to present at both a later age as well as a more advanced stage than women. More than 40% will have stage 3 or stage 4 disease at the time of diagnosis. The treatment for men with breast cancer generally is mastectomy with either sentinel lymph node biopsy or axillary lymph node dissection. 80 to 90% of men are hormone positive, either ER or PR positive, so most men will actually end up receiving some form of endocrine adjuvant therapy following surgery. And while overall men with breast cancer tend to have worse outcomes due to the fact that, again, they present at a later age and at a more advanced stage, once you adjust for those variables, men and women tend to have similar outcomes following treatment for breast cancer. Paget's disease of the breast, I mentioned it briefly before. 1 to 3% of breast cancers present primarily as Paget's disease. The typical clinical presentation is of eczema, bleeding, ulceration of the nipple areolar complex. This is secondary to infiltration of the epidermis with malignant cells. 80 to 90% of these women, maybe more than 90% of these women, will have an associated DCIS or invasive carcinoma somewhere in the breast, although not necessarily adjacent to the area of Paget's disease, can be in a completely separate location within the breast. Diagnosis in this case involves full thickness biopsy, including any involved area of the nipple or areola complex. Once the diagnosis of Paget's disease has been made, the patient needs to be worked up to determine whether or not there is a primary DCIS or malignancy somewhere else in the breast. The initial imaging study is bilateral diagnostic mammogram. This is one setting where if the mammogram is negative, MRI can sometimes be helpful to identify a primary malignancy. Treatment of Paget's disease is essentially the same as any other stage-matched breast malignancy. Without Paget's disease, it consists of either mastectomy or breast conserving therapy followed by radiation of the breast. The primary difference is that for patients with Paget's disease, they do need to undergo resection of the nipple areola complex, as well as a deep negative margin for tumor cells. Indications for sentinel lymph node biopsy in Paget's disease, patients who are undergoing breast conservation therapy for invasive disease, just like any other woman, and patients undergoing a mastectomy, even in the absence of an underlying malignancy, mainly due to the risk that on final pathology a small focus of DCIS or invasive carcinoma may be discovered. And once the mastectomy has been performed, at that point, they would have to undergo a complete axillary lymph node dissection. Patients who have had imaging workup, including mammogram and MRI, and still have no identifiable invasive or DCIS component, are still candidates for breast conservation therapy, which in this case would include excision of the nipple areola complex as well as a deep margin. And in these cases, while there's no strong data to support it, the NCCN guidelines do recommend at least considering adjuvant tamoxifen therapy for further risk reduction. Phylloides, tumors of the breast, cystosarcoma phylloides is the other term. These are a mixed epithelial and stromal tumor. The average age of presentation tends to be somewhat younger than women with breast cancer. 40 years is the average age. Sometimes they can be difficult to diagnose on pre-op studies, including ultrasound, FNA, and even core needle biopsy can sometimes be confused with fibroadenoma, particularly if the biopsy contains only the stromal or fibroadenoma elements. However, excisional biopsy is, of course, diagnostic. The histology of phylloides tumors varies from benign to borderline to malignant. Lymph node metastases are rare. Phylloides tumors tend not to metastasize to axillary lymph nodes, so there's really no role for routine sentinel lymph node biopsy in the treatment of phylloides tumors. However, if a patient does present with clinically positive nodes, if they have palpable lymphadenopathy or lymphadenopathy on preoperative imaging, these patients should be considered for either axillary clearance, or they can undergo a preoperative core needle biopsy of the lymph node to confirm whether or not they do have metastatic disease in their axilla. The treatment of phylloides tumors is resection with wide margins, as opposed to adenocarcinoma or to invasive ductal and lobular carcinoma, where there's not really any evidence that wider margins are better. Here, the general recommendation is to obtain margins greater than 1 centimeter. This is primarily due to the fact that phylloides tumors, the main complication is local recurrence of the disease. Interestingly, phylloides tumors tend to be frequently ER and PR positive. But despite that, there's really no role for endocrine therapy, and there's also no role for adjuvant cytotoxic chemotherapy in patients with phylloides tumor. As I mentioned, local recurrence is the main complication. They recur in 10 to 15% of patients. They can have distant metastases in 5 to 10% of cases. Local recurrence is generally treated with re-excision with wide margins. Sometimes this includes a mastectomy if there's not enough room to obtain wide margins and preserve the breast. The most common site of distal recurrence is in the lung, and once patients present with metastases from phylloides tumor, at that point they're essentially treated as a patient with sarcoma with metastases. So in isolated settings, patients with a single metastatic focus can undergo surgical resection if they're a candidate. And finally, I'm going to talk a little bit about patients who present with axillary breast cancer with no known primary in the breast. Anywhere from 3 to 5% of women will present with axillary breast cancer metastasis and not able to identify a primary lesion in the breast. Typically, these present as painless axillary lymphadenopathy, painless axillary mass. The diagnosis is made by ultrasound-guided core needle biopsy showing invasive breast cancer in the axilla, and a mammogram that's negative. And this is another situation that I mentioned earlier where MRI can be quite useful. Up to 70% of these patients will be able to detect a primary tumor on breast MRI. And once a primary tumor is detected, then again, those patients are just treated according to the specific stage and site-specific guidelines. The dilemma comes in patients who have positive axillary lymph nodes, but you're not able to identify a primary tumor either on mammogram or MRI. In these cases, the treatment is dictated by the nodal stage of disease clinically. In patients with N1 disease, so again, these are patients with mobile, ipsilateral, level 1 or 2 axillary nodes, the treatment options include either a modified radical mastectomy or an axillary lymph node dissection alone plus radiation of the whole breast to treat any residual disease or missed primary disease of the breast. Patients with more advanced disease, with N2 or N3 disease, again, that sort of falls out the realm of early stage breast cancer. But again, typically those will be treated with neoadjuvant chemotherapy followed by surgery as dictated. And then finally, for patients even with N1 disease, any adjuvant chemotherapy, endocrine therapy, Herceptin is dictated just as per the recommendations for their specific stage and grade. Patients with T0 N1 disease are 2A in their stage. So that completes the sort of, again, broad overview of early stage breast cancer. I'll be happy to entertain any questions at this point.
That was excellent, Mark. Dr. Jatoy, I think you're probably crying because he's not going into surgical oncology after that presentation. Dr. Dent.
Mark, I echo Dr. Swing. That was an excellent talk. It's probably the clearest talk I've heard on this topic, and it actually answered a fair number of questions for me. That being said, I still have two questions. Number one, you said if one or two sentinel nodes are positive, how many nodes do you take in a sentinel node? I'm not an oncologist, so I haven't really done this procedure, but do you really routinely take 3 or more nodes in a sentinel node? Or?
Not routinely, but on occasion. So essentially, and it kind of depends on what, and I don't recall off the top of my head whether or not they specify, if you're using blue dye to isolate nodes, then you keep taking all the blue nodes until they're all gone, which sometimes can be 1 blue node or 2 or 3. The same thing with if you're using radio-labeled isotope, then you keep excising nodes until you find your sentinel node, and then until you're less than 10% of the count in that initial sentinel node. So not routinely do you take more than 2 nodes, but on occasion you can take more than 2 nodes.
Okay. And then I'm particularly interested in your last topic here, which is the axillary mass. Partly because I got a patient with that as a chief resident and didn't know what to do. So I read about it and found it, and then it happened to show up on my written boards. And I think I was one of the few people in the room who may have known the answer just because of that experience. But the way it got presented, both as a patient and on my boards, was not adenocarcinoma of the breast. It was adenocarcinoma of unknown primary, poorly differentiated. And so you don't know if it's a GI malignancy, you don't know, what the other options are. And so what do you do in that setting?
Well, so in that setting, if it's not a clear breast malignancy, then obviously the first step would be, complete evaluation for any other source of malignancy. I think imaging, chest, abdomen, pelvis, CT scan, probably upper and lower endoscopy to look, mammography.
Okay. And then when all that comes back negative, now what do you do?
So at that point, I think probably what you do is proceed with axillary clearance, axillary dissection, and then further treatment depending on the final pathology of the complete specimen. See if you have a more definitive diagnosis based on complete axillary clearance rather than just core needle biopsy.
Okay, and that still doesn't tell you it's breast.
You treat it as a primary breast.
Yeah, 91% of them will be breast, even if the pathologist can't tell you that it's breast. At some point in the future, the breast cancer will make itself known in about 90% of the patients. But it's fairly uncommon to have axillary adeno of unknown primary, but it does occasionally show up. And so that's something that for the residents could be on your boards or show up in your clinical practice. Great talk.
Mark, since whether they're ER/PR positive or HER2 positive affects the prognosis, can we know how many women are affected, what percentage, what's the incidence that are of women, how many breast cancer patients are going to be ER/PR positive, since it's so important?
I'm trying to remember the exact numbers off the top of my head. I think that it kind of varies by age and by other, again, pregnancy. Patients are less likely. Younger women are less likely to be ER/PR positive.
Dr. Jatoy?
Yeah, so overall it's 77% in the SEER database.
For ER/PR?
ER positive.
How about HER2?
HER2 is about 25%.
About 25%.
Yeah. Well, I'll just bring up one point because this is brought up about the cell lymph node positive and the ACOSOG Z11 trial. What should we be doing? Notice the ACOSOG Z11 trial, this is what everybody knows, Mark mentioned it. showed that if you're cell lymph node positive, and the randomized patients are cell lymph node positive to either actually clearance or observation. And they found at the end of the day, after 6 years of follow-up, there's no difference in outcome. So the question is, should we implement this into practice? Well, there are a couple of problems with ACOSOG Z11. One is the target accrual for ACOSOG Z11, the planned accrual was 1,900 patients. ACOSOG Z11 only ultimately accrued about 870 patients. So it fell far short of its target accrual goal. So what does that mean? So if 1,900 patients are planned for a trial, and you only accrue 800 some patients, what's the implications of that in terms of interpreting the results of the study? Well, if 1,900 patients are planned, what that means is that with 1,900 patients planned, the investigators anticipated a 10 or 20% false negative rate if 1,900 patients had accrued to the trial. If only 800 some patients actually accrued, that means the false negative rate is going to be far in excess of 20%, which is beta. Beta is usually set at 20%. So it's going to be far in excess of 20%, which means the false negative rate is going to be far in excess of 20%. So are you willing to accept a trial with potentially a very high false negative rate? The other thing with ACOSOG Z11 is that everybody got radiotherapy to the axilla. So it's not like they were untreated. Everybody got radiation to the axilla. The third thing is that everybody had very minimal axillary disease. So if you look at patients who had cell lymph node versus those who had completion lymphadenectomy, the number of positive nodes are very similar in the two groups. So this is patients with very early disease with very minimal disease. And so extrapolating those results, for example, our patients, where we have patients with very advanced disease, I don't think is really applicable. And then the fourth thing is, of course, the majority of these patients were ER positive. 88% of the patients in ACOSOG Z11 were ER positive. Most of the recurrences in ER positives occur after 8 years, whereas the recurrences in ER negatives tend to occur before 8 years. And the follow-up was only 6 years. So most of the events are going to occur in the years that follow. So there may not be sufficient follow-up time to see the events that are going to occur and to really discern any sort of potential effect on mortality. So those are problems with ACOSOG 11. It's an underpowered study. It's got a very, the patients who presented had very minimal axillary disease. Follow-up time was only 6 years, when in fact with ER positive patients we need longer follow-up time. And finally, everybody got radiotherapy to the axilla. And so we know that radiotherapy to the axilla is just as effective as surgery in terms of reducing risk of local recurrence. But I don't think it can be extrapolated, or we can necessarily apply that to our patient population.
Is a patient ever considered cured of breast cancer? I mean, there was a time in the distant past where we said if you made it 20 years, and that's how long. Has that changed?
So cure, okay, is an interesting word, all right? So what is so?
Why did I ask him? I should have known. Okay.
So cure is when your annual risk, when your risk of death, when your hazard of death, you want to use the term hazard of death, approaches that of an age-matched population that's never been diagnosed with cancer. Okay, so that's cure. So do you ever achieve curing cancer? So Brinkley and Abel looked at hazard of breast cancer, and the hazard of breast cancer, the hazard of death, never approached an age-matched population that had never been diagnosed with the disease. So if you want to look at it from that perspective, it's not cured. Now what are these drugs doing? Okay, I mean, what's Herceptin doing? What's tamoxifen doing? Are they curing breast cancer? You see a 25% reduction in mortality. What they're doing, in my view, is they're pushing the recurrences outside the window of the trial. So 20% reduction in mortality means that 20% of deaths are pushed outside the window of the trial, so you don't see them anymore. So if you're following the patients for 7 years, now the deaths are occurring at 8, 9, 10 years, rather than within that 7-year window of the trial. So ultimately, we all die, right? So 20%, delay in death is just as good as a 20%. It's progress. So you shouldn't belittle the fact that we're actually delaying the time of death, because ultimately we're all going to die.
Surgical oncology, we all die. Okay, we got that. Dr. Rittenhouse.
You mentioned whole breast radiation, but you did not mention partial breast radiation. Could you address that?
Yeah, I sort of the randomized controlled trials that I mentioned in the comparing mastectomy to lumpectomy followed by radiation looked at whole breast radiation. There are some trials looking at partial breast radiation. I didn't really delve into those or look at them just because of the focus of the topic. So I sort of confined it to whole breast radiation in the context of the largest randomized controlled trials. I don't know, maybe Dr. Jatoy, is Dr. Oliver still here? No, maybe Dr. Jatoy can address that a little bit more specifically.
I didn't quite hear that.
Partial breast radiation as compared to whole breast radiation following lumpectomy.
So there's actually good talk about that here at San Antonio, and I don't know who went to the San Antonio meeting, but Jay Vadia gave a very good talk on the Target trial, which is localized radiotherapy versus whole breast radiation, and what he found is that local recurrence rates were similar, but what is interesting is that deaths from other causes were lower with targeted radiotherapy. In other words, you didn't have the cardiac deaths associated with whole breast radiation. Those are substantially reduced. So there may actually be an overall survival advantage to targeted radiotherapy because you're reducing all cause or death from other causes, namely cardiac deaths, because of the fact that you're localizing the radiation to the site of the tumor cavity, and you're avoiding the heart. So there may be an advantage. I mean that was early data presented at San Antonio at the San Antonio Breast Cancer meeting in December.
Actually, that's the largest breast cancer meeting in the world, isn't it?
Yeah,
That was started by two of our medical oncologists.
Yeah, it was started by Bill McGuire.
McGuire and who's the other guy?
And Chuck Coleman.
Coleman.
Yeah.
And they had done a lot of the research on ER/PR receptors, correct?
Actually, ER/PR was essentially invented here in San Antonio. So I think, that if you look back historically, this is where it all started.
We're bragging in front of our visitors. All righty, thank you. Very good, Mark.